So we had this young male who presented with fever, pain abdomen and vomiting from last 7 days. He had severe acute pancreatitis 2 months back and he recovered well with medical therapy. But now we did his CT scan which showed large wall of necrosis which is replacing body and tail of pancreas. So we are planning endoscopic guided cystotome to drain the collection. So we inserted endo ultrasound. As we insert endo ultrasound, the first station we reach is GE junction. Once you reach GE junction, then you have to rotate your scope clockwise and slightly push the scope into the stomach and try to locate the pancreas and its surrounding collection. So as we assess the collection, we see lot of hyperdense content into this large cavity which suggestive of solid debris. Then we measure the collection size. As you can see, we have to measure in both the axis, short axis as well as long axis, and in this case it was more than 12 cm. We further see the cases and you can see here there is lot of solid debris we can see inside the cavity which suggest of wall of necrosis. Next step is to assess the right window to puncture. Two things has to be seen. One, the obvious blood vessel using your color flow, and second, the distance between the stomach wall and the cavity wall. We are using hot Axios for this procedure. On right upper end, you can see the sheet of the stent at the gastric end. We are again reassuring the blood vessel free window, and also we are measuring the runway because it is 1.5 cm stent. We require at least 3 cm of the runway so that we do not injure the opposite wall. Once we are all good, we put our paddle on the pure cut and by single shot we enter into the cavity. Once we are inside the cavity, as we can see in this endoscopic view, we lock the sheath and then we open the distal flange under vision inside the cavity. Once distal flange is open, then you pull back the stent till it is completely deformed, and then we open the proximal flanks into the channel itself. Till now we have not used the endoscopic view, but now once you open, you turn out to endoscopic view, turn to the right side, push the sheet down and you can see the fluid gushing out, and even you can see the proximal flange. So this is a final release which we can see even on the endoscopic as well as fluoroscopic view. You have the sheet, otherwise you can displace the stent from its position, and as you can see the whole gush of the pus which has come out in the stomach. Generally we do this procedure under anesthesia. Patient is intubated so that to prevent any kind of aspiration to the patient. So a large amount was pus was aspirated from this patient, and you can see the stent which is properly placed. We are trying to see inside and see lot of still the significant amount of pus is coming out of the cavity. Now once this step is done, next step is either you leave this to stent and try to dilate in the next session, or you can dilate even in the same setting as we are doing. You can dilate up to 12 mm to 15 mm on the first session, and once you dilate it, you can see the cavity clearly via stent. And when you see inside, and you can see a whole lot of solid debris which are inside the cavity. This solid necrotic debris we might need to take it out on the next session by doing endoscopic necrosectomy. Then after that, we always in our practice put a plastic stent inside this metal stent to avoid any kind of adverse event due to the metal stent. Thank you.